Hi, my name is Shanna Miranti, and I am here with my dear friend Leigh Ann Pansch, and we are going to talk today about prescribing hope in atopic dermatitis. Leigh Ann, it's so wonderful to see you again, and I love being able to have the opportunity to sit down and just discuss how we start to manage patient care. So my question for you today is, with all of these fantastic beyond steroidals on the market and all of the new tools in our toolbox, how do you decide where to go and where to start, how to manage a patient, and how to assess what they're going to need first?
I think that's a great question. I think the thing that really pops into my mind first is just the realization that if you really sit down and think about it, if you're a practicing nurse practitioner or physician assistant in dermatology, how many of your patients, by the time they make it to your clinic, have actually previously been prescribed a therapy, probably a topical corticosteroid,
Absolutely.
maybe another therapy, but I want to give them something new, something that they haven't used yet, and specifically one with a more favorable safety profile, one that they could use long-term chronically across mild disease, moderate disease, and severe.
Absolutely.
And so, those are the kinds of things that I think about specifically, then just saying to you, I see a lot of kids in my practice.
Same.
And so I really have to stay on top of what non-steroidal therapy, because that's my ultimate goal, involves each individual age group.
Absolutely.
And so
if you're looking at safety, obviously we have a number of options now in our beyond steroidal category, and they all have different age indications. So say we're talking, that preteen, teenager that comes in and has tried and failed so many topical steroids, has been prescribed so many topical creams. How do you convince them that these new medications are different, that they are not the same old tube that they've tried before, and that they could actually have even maybe better improvement in their itch?
It's a great question, and I just have to say, I think our patients are already thinking that. It's interesting as I talk to peers, how many of my peers are like, wait, non-steroid? Yes, we need to be talking about these things like steroid withdrawal, even more so in kids.
Absolutely.
Concern for HP axis deficiencies and the like. And so, I think it's really a lot easier than thought. What I like to do is get an understanding of what they've tried, make sure that it's documented.
Sure.
And then if I have a patient who, say, has had subpar improvement with a TCS, or if I have a patient who's using a TCS a little more frequently than I feel very comfortable with,
Sure.
Those are both patients that I think are great candidates for a topical therapy.
Absolutely.
And then if it's a preteen, specifically if my patient is complaining of itch, I really think about ruxolitinib. And something really resonated with me in the past year when they published data about on application within a few minutes, patients can have itch relief. And so I think this is something that really patients want to hear. Certainly we know that itch is a huge component of AD. And I think if we're improving their itch and they give it a little bit of time, that we could do non-steroid.
Absolutely. So with ruxolitinib cream for our 12-year and older patients, there are actually, as you mentioned, the 15-minute itch relief data, which are so fantastic to be able to tell a patient, to give them that reassurance that we can make your itch considerably better in just minutes. So imagine, what that can look like extrapolated over days, months, what have you. And also simplifying regimens for patients. I'm a mom, I have 4 kids, and I feel like if I can make that mom's life easier and let that mother know that her teen can be in charge of that tube and use it, on their eyelids, use it in sensitive areas, it's okay, it's safe. They no longer have to police, you can only use this cream in this area and this cream in this area. Having one tube definitely simplifies that patient's getting ready time in the morning or at nighttime. So I think that is often overlooked, I think, in clinic. We want to give our patients options and solutions that are safe, that are effective, but that are also easy and that can make that patient's life a little bit easier too.
Yeah.
So when you're initially seeing a patient, do you oftentimes put them into a biologic or non-biologic candidate? Like, are you automatically assessing? Are you automatically looking at severity? Are you automatically trying to decide, which way to go from that first moment?
Absolutely. I think that there are some patients, be it prior history, be it comorbidities, where I look at this patient and I establish you're definitely a systemic therapy candidate. But the reality is that regardless of if a patient's on systemic therapy or not, they're still going to need a toolbox for if their disease flares. But specifically for those patients, I have to say I've been really incredibly surprised at the volume of patients who you give them a tube, a little sample tube, and you order one of these topical non-steroidal therapies, and you see them back in a few weeks to maybe consider, maybe you're going to do some injection training for systemic therapy or review some lab work for consideration of an oral therapy, and how much improvement they've had in a small period of time.
Absolutely.
And it's great, those interactions with patients, especially parents who now are like, wow, all it took was this cream,
right?
And we didn't have to go the route of systemic therapy. Those are some really fun visits.
Yeah, of course we all see those terribly heartbreaking cases that are going to need the systemic therapies, the biologics, right off the bat. But you brought up a great point. If we can potentially prescribe something and prescribe hope that maybe they don't need to go to a shot, maybe they don't have to take a pill every day, maybe we can get their disease under good control, and then give them the tools to be able to help them manage their disease. I think that that's just so fantastic. So it sounds like we're kind of on the same page with
Absolutely.
the way that we address these issues with our patients. So for all of you out there, continue to prescribe hope. Remember to discuss, these options with your patients with atopic dermatitis, and remember ruxolitinib cream as a wonderful option for your 12 and up patients.